Welcome to Key Insights. I'm Corey Langer, Director of Thoracic Oncology at the Abramson Cancer Center, University of Pennsylvania, where I'm a professor in medicine. And I'm joined today by Josh Baumel, who also works in medical oncology, assistant professor of medicine in the division. And we are speaking here today after the 22nd Annual Perspectives in Thoracic Oncology meeting in Lower Manhattan, New York City. A lot of interesting data have emerged over the last year that really been trailblazing and I would argue have changed the therapeutic paradigm. And Josh, I just want to start off with some of the more recent data for oncogenic drivers, specifically the FLORA trial. This is a trial that had high expectations comparing a second or third generation TKI, in this case osimertinib, which had already established a role in patients with T790 mutation as part of their acquired resistance, and compared that agent to frontline treatment with erlotinib or gefitinib, sort of a dealer's choice approach. It was strikingly positive. We saw quite an improvement, at least 8 or 9 months in median progression-free survival. Duration of response was clearly much better, and toxicity was considerably lower. So what is your take on this trial? Do you feel it has changed the practice paradigm, or do you think we need more data?
I do. I think it has changed the practice paradigm. Previously, we were giving either gefitinib or erlotinib or afatinib in the first line, and then for those 40 to 60% of patients who developed a T790 mutation, we were giving them osimertinib in the second line. But in that doing, we're losing 40 to 60% of patients who are not able to benefit from the receipt of that drug. So I think that when you have the fact that the medians are basically additive to the point that you have that 18-month progression-free survival with osimertinib with improved toxicity, I think that in and of itself is already appealing. And when you look at the curves, osimertinib and the gefitinib-erlotinib curves separated very early. And so we saw that osimertinib was really providing a benefit for a lot of patients. And the other thing which is interesting, which was surprising to me, was that the overall survival curve even showed a trend towards improvement, which is very remarkable when we consider the fact that when compared to chemotherapy, the first generation tyrosine kinase inhibitors do not consistently show an overall survival.
Not consistently, although in a nested analysis in Lux-Lung 3 and 6, we did see an advantage with respect to survival for afatinib compared to at least standard chemo combos, pem-platinum or gem-platinum. But that was truly an unexpected bonus. I had not anticipated those data. It wasn't quite significant. They were very rigorous about the statistical insights that this generated, but the trend was clearly there. The OS curves were almost beginning to match the PFS curves. So what do we do second line? How do you approach that? Unfortunately, resistance is probably inevitable in the vast majority of these patients, and although we've pushed progression-free survival out to 18 or 19 months at median, the majority of these folks, unfortunately, are probably going to have progressive disease at 2 years. So what's your approach there?
So I think there's some emerging data, at least in the second line use of osimertinib, regarding mechanisms of resistance, which were presented at the World Lung Cancer Conference in Japan this year, which were fascinating. So we know now that the primary mechanism of resistance, accounting for about 50% of patients who are resistant to osimertinib, is first MET amplification, which can best be identified on FISH, and second, a C797S mutation, which is an additional resistance mutation. Now, that's important because the C797S mutation, it turns out in vitro, if it's not present with T790M, is sensitive to the first generation tyrosine kinase inhibitors. So one could imagine that a patient who progressed on osimertinib first line, then developed C797S, would be a candidate for receipt of erlotinib, gefitinib, afatinib in the second line.
So would they continue the OC with that, or would they switch?
So
or is
I
that
would
unclear?
probably in that situation pull back the osimertinib and just give the erlotinib, gefitinib,
assuming
afatinib.
T790 hasn't emerged.
Right, so that's the other aspect that gets complicated. When it's used in the second line, that C797S can occur on the same allele, so-called in cis, or on a different allele, so-called in trans, to the T790. When they're both present, if they're in trans, that C797S is on one, T790M is on the other, then I would actually continue the osimertinib to manage the T790 and give the erlotinib, gefitinib, or afatinib to manage the C797S.
Right.
And we're now seeing multiple case studies showing that that works. And then for the other group, those patients who develop MET amplification, we now know that crizotinib is a highly active drug for patients who have MET activated tumors. And there are some emerging case series showing that continuing the osimertinib and adding in a drug like crizotinib can improve outcomes for these patients.
Particularly for MET, and there's several other compounds that are being developed. And of course, there's still the prospect, unfortunately, of small cell transformation.
Yeah.
And HER2 has been identified. So it's an emerging field. I think the bottom line is that we will be doing both liquid and tissue biopsies to try to better delineate the mechanism of resistance in this population. And it's a field that's truly emerging as time goes on.
I think it's a central aspect of targeted therapies, that anytime you're giving someone a targeted therapy, it's important to check a biopsy or a liquid biopsy at the time of progression to assess for the mechanism of resistance, because that resistance is heterogeneous. Some people develop it by one mechanism, and you'd imagine you'd want to treat C797S different from small cell transformation.
Absolutely. The final common pathway for the vast majority of these patients will still be chemotherapy.
Absolutely.
And since the vast majority have adenocarcinoma, or at least non-squamous, it'll probably be a pemetrexed-containing combination, either PEM-carbo or PEM-carbo-bev or a taxane-carbo.
Yeah, these patients tend not to respond very well to single-agent immunotherapy, at least in meta-analyses based upon the trial data. And so I completely agree that after you've exhausted your tyrosine kinase inhibitor-based targeted therapies, chemotherapy is the way to go.
Ahead of immunotherapy.
Absolutely.
Yeah. I guess the same sort of data have emerged for ALK translocations. Last year at ASCO in 2016, we saw the J-ALEX data, which showed an advantage for alectinib over crizotinib in those with ALK fusion proteins. And this year, the global ALEX trial at ASCO was presented and pretty much replicated the data that was seen in Japan, with a median progression-free survival that was more than double that observed for crizotinib, the former standard. So we were going from 10 months to well over 24 months, I think, on average. And then we also observed the added advantage of a major reduction in CNS progression at 1 year, from over 40% to about 9 or 10%. So there too, do you feel that alectinib has essentially replaced crizotinib as frontline treatment for ALK-positive patients?
I do, and I think it's interesting because the mechanism of why I think it's working better is different. So in osimertinib, I think the reason we're seeing such a benefit is that the T790 subclones are likely present in that tumor early, and we're preventing expansion of those subclones. In the case of alectinib, I don't think that's what's happening at all. If you look at the resistance mechanisms for alectinib and crizotinib, what you see is that alectinib leads to much greater ALK inhibition. Patients who are resistant to alectinib have a much higher rate of ALK mutation. And so I think this is just a tighter target on ALK. And so I personally, for a patient who has ALK translocation, I'm using alectinib first line, completely replacing crizotinib in that space.
That's now been FDA approved.
It has.
So there too, we have the same question. What do we do when individuals develop resistance to alectinib?
So it gets a little bit complicated, right? Because the resistance mechanisms for ALK inhibition depend not only on the presence of an ALK translocation, but also about what drug you give. So again, it's essential to do a repeat biopsy or liquid biopsy to identify the mechanism. The most common mechanism of resistance to alectinib, as well as to many other ALK inhibitors, is the so-called G1202R mutation. And this is sensitive, certainly in vitro, to an emerging drug which is currently in clinical trials called lorlatinib. However, there are some phase 1 data to indicate efficacy for brigatinib, which is currently FDA approved in the crizotinib pre-treated patient population.
So there are plans for a big master trial that'll essentially enroll all of these patients who are experiencing disease progression, acquired resistance to alectinib. Of course, how to actually assign patients to specific approaches and whether a randomization even makes sense in this setting is not quite clear to me.
Yeah.
So what would your approach be if you were sort of the czar of clinical trials in this setting?
It's good to be the king. So I think that the key element is looking at the in vitro data, looking at what we see about sensitivities, such that we know that G1202R is highly resistant to crizotinib. So if I had a patient on alectinib, they develop G1202R, I'm not going to give them that drug. And taking a look at the data which are available to say, here is my best bet. And it's going to become more and more complicated as we get into these smaller and smaller subgroups. We're not going to be able to do a phase 3 study looking at all of, not even the G1202R, what about the less common resistance mutations for ALK? So I think using that in vitro data is critical, and then using retrospective analyses to follow this, and see what happens to these patients so that we know for the future.
So we really witnessed a sea change in how we approach patients with oncogenic drivers, at least the most common oncogenic
Absolutely.
drivers. I want to switch to immunotherapy. Certainly that has sort of sucked up the vast amount of oxygen remaining. And when we think about the patient population, it's really a much larger group, a much larger pool of patients. If we figure that ALK is 3 to 7% of the entire non-squamous population, and EGFR, depending on what part of the country you live in, is 10 to 15, maybe 20% on the West Coast. Ultimately, the rest of the population would be potentially served by immunotherapy. So last year, we observed the data at ESMO and been published since in the New England Journal showing us a major advantage for single-agent pembrolizumab compared to standard platinum chemo in individuals with 50% or higher PD-L1 expression. Do the math, it's about 30% of the overall non-squamous, well, actually the overall population, not just squamous, not just non-squamous, but squamous as well. And then again last year and updated this year, we had the randomized phase 2 results for KEYNOTE-021G, which showed clearly a response and PFS advantage for the triplet, pembro with pem-carbo, versus chemo alone in the non-squamous population. And then this year at World Lung and also at ESMO, we had updated survival data, and something that we hadn't expected. The survival curves are starting to separate despite crossover from the control arm to single-agent pembro. Literally 3/4 of the patients were able to cross over. So how does this influence our therapeutic decision-making in the majority of patients really whose tumors do not harbor a oncogenic driver?
I think that it's become a very confusing landscape, certainly. For patients who are greater than 50%, I have routinely been using pembrolizumab monotherapy based upon KEYNOTE-24. However, in 21G, there was an 80% response rate for patients who received the triplet. Based on the fact that it's still a randomized phase 2,
There were only 20 patients who were in that group.
Not a lot of patients. I haven't been uniformly using that triplet for all patients. However, if I have a patient who is highly symptomatic, for whom I think I only have one shot on goal, I have done it on occasion. For those patients who have less than 50% staining, it still is complicated because it's unclear to me whether patients would benefit more from having the triplet with carboplatin, pemetrexed, pembrolizumab, or simply receiving carboplatin, pemetrexed with or without bevacizumab, followed by immunotherapy, recognizing that most of these patients will move on to immunotherapy.
It's important to note that both 024 and 021G did not include bevacizumab.
That's true.
Whether we really feel it adds substantially to chemotherapy, we've never proven it in the context of a PEM-carbo platform, only in the context of paclitaxel and carboplatin. So I pretty much agree with your approach. I think for those with greater than 50% or expression, pembro is the standard. For patients who are, whose performance status is starting to decline, who have high metastatic burden, who are highly symptomatic, the triplet becomes a very attractive option. What kind of studies do you perceive occurring in that group? Where do you think we need to go beyond considering the triplet and the 50% or higher population?
Well, I think that certainly the data from the other chemoimmunotherapy phase 3 studies will be highly impactful to know sort of what the next step will be. But I think the other critical point is identifying what biomarkers really get at what is happening here. PD-L1 is on the cell surface. It's highly heterogeneous, it's highly dynamic. And so as a result, it's an imperfect biomarker. There are some emerging biomarkers that help to better identify responses to immunotherapy. Here I'm thinking about tumor mutation burden is the most established, where we've seen that patients who have more tumor mutation burden, such as patients who have microsatellite unstable tumors, are more likely to respond to immunotherapy. Yet even that is a blunt instrument because not all mutations are created equally. There are some emerging data looking at gene expression profiling, looking really in the cell, what's happening that might make it more likely to respond to immunotherapy. And some more work that's been done partially at Penn is looking at T cell exhaustion profiling, saying we're going to do flow cytometry of these T cells, identify when the T cells become reinvigorated from the immunotherapy, and how can we track that to associate with the response to immunotherapy. And I hope that these sorts of parameters will allow us to administer combination immunotherapy or even chemoimmunotherapy in a more intelligent and rational fashion.
So at least going forward, all prospective randomized trials should ideally integrate TMB, tumor mutation burden, with PD-L1 testing. I guess in that regard, the CheckMate trials have been highly informative. Even though they were negative, we observed data that showed that individuals with high TMB and high PD-L1 were the most likely to respond, but that you could probably identify a population with high PD-L1 but low TMB who are much less likely to respond.
I thought that was one of the most eye-opening aspects of the presentation, because if you look at the curve, it really separates the two groups. High TMB, high PD-L1, very nice response. If you even look at the low, medium TMB and high, greater than 50%, they don't do so well.
No.
And the other way is true as well. Those patients who have high PD-L1 and low TMB, both ways, they don't do as well. And so this emphasizes these are surrogate biomarkers, and we've got to really get to know what's happening in the tumor. The goal is to have something like EGFR or ALK, where we know this will work or this won't.
I don't think we'll ever quite be at an EGFR. I mean, that's sort of
I
a
can
binary
hope. I can
approach,
tilt at windmills, but
I think it will be an amalgamation of various markers, and I think we'll become a lot more intelligent about who's most likely to benefit, who's less likely, and who will truly not benefit.
Yeah.
What about the duration of treatment? We, both the 024 and 021 trials, at least for Pembro, there was a sort of an arbitrary decision to stop therapy at 2 years. Do you have any data that are really looking at the optimal duration? Should we stop at 2 years? Should we keep going if someone's tolerating the therapy well and is not having much in the way of toxicity, and they clearly having an excellent benefit radiographically? Are there any randomized data that can help inform that decision?
So this has recently changed. Up until ESMO, I would have said, based on the melanoma data, they saw that patients who finished 2 years, most of them retained their response for over a year of follow-up without any further treatment. And yet, at ESMO, they presented CheckMate 153. This study took patients who had completed 1 year of nivolumab and then randomized them to either continuation nivolumab or stopping. Now, 1 year is different from 2 years, but still, I expected these would be similar curves, but continuation nivolumab was much, much better. The hazard ratio was 0.4 for the progression-free survival, and the rate of reclaiming your response at the time of progression was relatively poor. So at this point, based on CheckMate 153 in lung cancer, I'm continuing PD-1 inhibition until progression or poor tolerability.
They did not observe a survival difference, but again, it was still very early data, so we don't really have much data beyond 2 years, and I think we were starting to see a little bit of a separation there. So in the absence of toxicity and the presence of a good response or at least stable disease, you'd keep going.
I would.
And so would I. I pretty much had the same attitude that, well, 2 years was sort of the cutoff, but this discussion has come up in clinic now where I have patients on either Nivo or Pembro up to that 2 year point. I too, up until ESMO, would probably have recommended at least considering stopping, and now I'm a lot more gun shy about that. I'm a lot more reticent. What about toxicity? Immunotherapy presents a peculiar challenge when it comes to toxicity. We're not dealing with the traditional chemotherapy side effects. We're not dealing with hair loss, not much in the way of significant nausea and vomiting. Myelosuppression is pretty rare, but there's a whole constellation of other side effects that really present significant challenges. And how do you deal with that? And at least in your experience, what have been the most significant toxicities that you've dealt with?
So I think it's very important to remember that while we're talking about immunotherapy, we say, oh, no hair loss, no nausea, vomiting, the toxicities that can occur are quite serious. So, immune-related adverse events happen, somewhere 5 to 10% of the time, depending upon the trial that's studied. The big one that we worry about in lung cancer is pneumonitis. And pneumonitis is very important to remember about because we have patients with lung cancer, they often have shortness of breath, they often have cough. But in a patient who's receiving a PD-1 or PD-L1 inhibitor, it's very important to consider pneumonitis because if you miss it, the outcomes are very poor. But if you identify it and initiate treatment with high-dose steroids, the outcomes are excellent. And in fact, in one series, 75% of patients who received treatment with steroids for their pneumonitis were able to be retreated successfully with PD-1 inhibition after completion of their steroid taper. And so it's very important to identify these things early and intervene. Patients are often reluctant to hold treatments, but what we've seen from the melanoma data as well as from the lung cancer data is that patients who have immune-related adverse events can still benefit from treatment. Indeed, there's some data saying that they may benefit more, that it's a sign of the immune system.
And that some of these patients may actually continue to do quite well even if their treatment is suspended.
That's exactly right.
I know you've had at least one patient, I believe, developed fairly frank diabetes.
Yep.
It's a head and neck patient, but the same principles apply. And there was some question, because it was quite serious, I think it was at least a grade 3 event, whether that patient could continue on clinical trial. Did that patient continue?
They did. I mean, and the key point is that with these endocrine abnormalities, specifically type 1 diabetes as well as hypoadrenalism, these are irreversible events. So the drug has led to T-cell infiltration of either their pancreas or their pituitary, and those cells are gone. And so continuation of the therapy does not pose a significant risk for the patient at that time point. Once you put them on appropriate replacement therapy and has potential benefit for their cancer control.
And certainly probably the most common side effect, although it's usually grade 1 or 2, is hypothyroidism.
Right.
Which
but
is
that doesn't
easy to fix.
Yeah, that doesn't usually interrupt our day too much.
Although it can occur quite acutely. So if there's sudden unexplained fatigue or lassitude in a patient, it's imperative we check their TSH and probably also check their adrenal pituitary axis.
Yeah, the latter is absolutely critical. I think we're all trained to look for the TSH, but if you don't find anything on the TSH, I think stopping there is dangerous because hypoadrenalism does happen in these patients.
You need to do an ACTH and need to do a cortisone stimulation test or some variation on that. What's your general management for the non-hypothyroid toxicities?
So I generally will give somewhere between 0.5 milligram per kilogram of prednisone or the equivalent up to 1 milligram per kilogram. And then I'll give that for a couple of weeks until it is well controlled, and then I'll taper over 4 weeks. That taper is really critical because it prevents a flare as they're coming off of the steroids.
And will you re-challenge these patients?
I will for most adverse events. We saw last year at ASCO some data that the differential immune-related adverse events have different instances of recurrence. So for instance, pneumonitis, relatively low as we discussed. Colitis is higher. And so someone who has severe colitis, I might be a little bit more hesitant about re-challenging them. But still, if the patient is motivated, we can at least do it if they're feeling well.
But this too is an emerging field. I think we need more insights into how to optimally manage these folks. Steroids are at least the stopgap answer. I think we need to have a little bit more information on some of the folks that have been excluded from these trials.
Yeah.
Individuals with pre-existing autoimmune disease where there was essentially an arbitrary decision to not enroll, and we need nested safety trials in that group to figure out if we are truly exacerbating the underlying autoimmune disease or whether the presence of that autoimmune disease somehow influences the sensitivity of these patients to IOs. So this has been a wonderful discussion. My name is Corey Langer. Again, welcome to Key Insights, and thank you for your attention.